It's me, Jeremy Pettus. So it's nice to see everybody. I'm here with my co-panelist, Leslie Eiland. Can you wave, Leslie? Here's Leslie and Kerri Sparling. I'll have you guys introduce yourselves in a second, but we're all living with type 1 diabetes. And I just want to say first, sincere thanks to everybody for joining today. I mean, there's literally months of work that go into making this conference. And it occurred to me that right now is the only time that I'm actually on live to kind of talk to everybody. Everything else is pre-recorded, and I've been kind of watching myself and doing the chat, which has been fun. That's how I chat. And so it's nice to be here and kind of interact with you all. And we're in the TCOYD office, and Steve's down the hall, and other TCOYD folks are here. So it's a fun day. It's very different than the in-person conferences, but it's great to do this. So some housekeeping issues. So this is all about discussing, taboo topics in type 1 diabetes, which has obviously been, there we go, got the frog in my throat, the whole theme for the day. And when we're doing this Zoom meeting, I'm still learning Zoom myself. There's two functions of kind of interacting with us here. So there's the chat box, which you can see down at the bottom, is literally, it says chat. And if you want, this is where you can just make comments or, respond to other people chatting. And when you do that, at the very bottom, there's this little blue box, and make sure you click on that and click to all panelists and attendees. If you just keep it on panelists, it'll only go to the three of us. So if you want to interact with everybody, make sure you do that. And again, that's just for more like comments, like whatever. If you actually want to ask questions about taboo topics that have been, or things that have been bothering you on your mind, whatever, that's the Q&A button, which is kind of over here on the bottom right. And when you do that, you can just ask your question if you want. There is a checkbox you can click to make your question anonymous. I'm glad I'm learning how to pronounce that word. It's been a tricky one all day, anonymously. You can check that, and then it'll just come up as an anonymous question, and we can try to answer it. So those are the two kind of functions of Zoom. The last thing I want to make sure is that to remind you guys that there is a button to donate in the auditorium at TCOYD or on our website. That again, everything for today for participants is completely free, but it takes a lot of effort and funds, frankly, and we rely on donations to keep these things going, especially in COVID times, doing this all virtually. So that is my whole spiel. For those who haven't met me, I'm Jeremy Pettus. I have type 1 since I was 15. I'm an endocrinologist here at UCSD, and I work at TCOYD running kind of like the type 1 side of things, obviously along with Steve Edelman. And I'm going to throw it to my panelists to introduce themselves. But again, it's a whole type 1 crew. So safety tree, all that good stuff. So let's start with you, Leslie, if you can just, introduce yourself, and we'll go from there.
Sure. I'm Leslie Eiland. I am an adult endocrinologist at the University of Nebraska Medical Center in Omaha, and I was diagnosed with type 1 diabetes when I was in medical school.
Okay. And what about you, Kerri?
I don't know if I can trump that. Diagnosed in medical school is hardcore. I was diagnosed when I was 7, so my parents did most of it for me for a long time. But my name is Kerri Sparling. I live in Rhode Island. I have not left Rhode Island in a year, so it's really nice to see all of you guys today. And I work in the advocacy space. I used to write a blog for a long time, and I get to hang out with Jeremy and Leslie, so I'm stoked.
Yeah, we just got one question that said, awesome Zoom lesson, thanks. I think that was sarcastic, but I'll take it as a appreciative comment. All right, so, you guys can keep kind of monitoring the Q&A also, but we were talking before we jumped on here in terms of like taboo topics, things that have been coming up during the day. And, we wanted to start with something, and a lot of, one thing that people have been asking about a lot is, are we going to talk about weight? And that's obviously a big topic. Some people are trying to lose weight, some people are trying to gain weight, and everything in between. But to start with this, because it's not really a taboo topic, but it's something that a lot of people with type 1 diabetes struggle with. It's not something that a lot of people in general struggle with. And again, it's not something that we talk about much. On the doctor side, when we talk about type 2 diabetes, it's kind of the next thing out of our mouths, that we have to address weight and insulin resistance and stuff like that. But when it comes to type 1s, we forget that most type 1s in the country, actually 2/3 of type 1s in the country, are either overweight or obese. So it's very, very common. And there's reasons that type 1s might be prone to gaining weight. Obviously we have to take insulin that can predispose us to low blood sugars and eating more, or just being afraid of low blood sugars and eating more. And exercise can be a pain in the butt. So it's hard to kind of balance all that. And of course it can lead to weight gain and just issues with weight and maybe food in general. So I don't know, throwing it to you, Leslie, Kerri. And also like setting up the context, obviously Leslie living with type 1 and we're endocrinologists, and Kerri, you're not an endocrinologist, but that's on purpose. But because I just wanted to say that because we're coming at this with different perspectives. And that's important. So Leslie, do you want to maybe talk in general about how this comes up with patients or how you deal with it?
Yeah, I would agree. It's super common, and it's really challenging to talk about. I think when people are trained as endocrinologists, I think weight and obesity medicine is more of a focus now, but it wasn't, even when I was a fellow. So we got not a ton of training about weight management, but it is extremely common. When I have somebody who's gaining weight, first I want to look and make sure they're not having a ton of hypoglycemia. Are they eating a lot of carbs when they don't want to be eating a lot of carbs? And that's one sort of not easy fix, but it's kind of the first thing I go to. One challenging thing that I have is when people want to go on these like pretty restrictive diets, like these cleanses or fasts, and they do it without consulting us. And it usually doesn't go well if they're doing extreme calorie and carb restriction, because they may have a significant decrease in their insulin requirements and a lot of lows. And it can be challenging. And so even when they do ask for our assistance and we work with them to decrease their insulin needs, then if that doesn't go well, or if they sort of fall off the wagon, I find that they're embarrassed to reach out and say like, I'm not doing that anymore. I'm like back to my old ways. And so they come in with really high sugars that they've had for like a month or so, because they were kind of embarrassed to reach out and say like, that didn't go well and it was too restrictive and I didn't enjoy it. So I ask people just to be honest and let us know, when they're going to try something that's new for them. And if it doesn't work out, that's fine. Just reach out and we'll help you kind of readjust.
Yeah, and some things in the chat box, and Kerri, I'll get your take too, is, people asking in general, can I do low carb? Can I do keto? Can I do intermittent fasting? And the short answer is yes. People with type 1 diabetes can absolutely do these different diets, including intermittent fasting, which, a popular one is basically people stop eating after 8 p.m. and don't eat again until noon the next day. And as long as your basal is kind of in the right ballpark, you should be completely fine doing that. And that's just restricting your calories between noon and 8. That can work well for some people because it's more of an easily conceptual fix of I just eat during these times and not during those times. Same thing with low carb. It doesn't mean you have to be hungry, but you just, to try to avoid carbs can help. And Kerri, any comments you want to make before maybe we go to next topic?
I just like that I'm not an endocrinologist on purpose. It's like I didn't go to medical school just so I could have this conversation as a layperson, but that kind of folds into it. There's an embarrassment quotient to going in and talking to my clinician about, like, there's so much attention paid to numbers. They're looking at my A1C, they're looking at my time in range, they're looking at my weight. And I'm like, I can't juggle all of these things at the same time. So a lot of times when my A1C and my time in range are an optimal range, that's when my weight tends to creep up. And I can't figure out what's causing that. But just having those discussions with my endo for a long time was a little mortifying because I wanted to make it seem like I was on top of everything. And it was kind of shameful to admit that, like, I had no idea what I was doing. And another frustrating thing was when you go and do the exercise bit and then you have to eat your workout basically at the end of it. So how often have you been exercising and you're going to have to mainline a couple of juice boxes and you're like, damn, I just broke my calorie threshold by eating after my workout. That's so frustrating. But I found it's really helpful to talk to other people who have diabetes, to crowdsource the anecdotal stuff that works for some people to see if that will fit into my life. And that's where my peers have been a really big instrument in helping me deal with exercise and attempted weight loss and stuff, because I feel like I've got a team of people that really get it. And not only do they get it, but I can be super honest about the stuff that I'm just like hardcore failing at.
Yeah, and thanks for mentioning that. I mean, the weird looks I've gotten while like drinking a Pepsi on a treadmill. I mean, it's just like, and that's when you want to just scream, because there you are, like trying to work out, lose weight, whatever, and you go low and you're like, great, I gotta like down a couple hundred calories just so I can try to lose weight. It's really frustrating, and that's common. People are asking about diabulimia and official kind of like diagnoses of that. And we have a whole talk on the like bonus section specifically kind of addressing that. Okay, so just going through the Q&A, and these don't have to be kind of taboo topics, but so I will get to some of these. But I wanted to mention, Kerri, you talked a little bit about the shame of addressing these things with your endocrinologist, and this is something that Leslie and I were talking about before we put this on. Is this whole kind of dance we do? As somebody living with type 1 diabetes, when we go and see our healthcare provider, there's the information that you tell them, and then there's kind of the stuff about what you think they want to hear. And a lot of times that can lead to you just come out of that appointment with no practical information because you just basically lied the whole time. Mm-hmm. And that's not to like shame anybody. I've done that myself. And it's a weird setup that, you're going to see this person that's supposed to be helping you, but because of so much shame and guilt you have, you don't actually tell them that you're forgetting to bolus or that, that you're taking your pump off sometime, and you hide those things. And how do you feel about that? Or how can we break down that barrier of just, being honest or creating that rapport maybe with your practitioner?
From my perspective, if I'm dealing with stuff at home and I write it down in the notes feature on my phone, and then I make myself read those things out loud when I get to the endo's office, that's really helpful because there's no shame in writing down the crap that I'm struggling with in the moment, right? It's more iterating that once I'm at the doctor's office. And so I found that if I have it on my phone and it's in front of me and I'm going there with the intention to share it, I'm more apt to follow through and be like, here's what I'm dealing with, read this note. But it has helped that my endo has type 1. And the thing that he and I struggle most with is if my A1C is like in garbage can mode for me, sometimes he has a tendency to be like, oh, that's all right, mine's worse. And I'm like, no, you need to help me reach my goals, not your goals. And we kind of struggle with that a little bit. But being urged by him and other healthcare professionals to be honest with them and being given space to fail openly helps me succeed more. Getting it out there is really useful.
Okay. Thanks, Kerri. Other thing, I'm just going through the Q&A, and it's a lot of like specific things about, different approaches to diabetes and blood sugar management. Something that's come up again is that we haven't specifically addressed today, and we should, is COVID and type 1 diabetes. And there's been a lot of talk about, what level of priority people with type 1 diabetes are. We've published some papers actually showing that people with type 1 diabetes are at increased risk of complications at the same level of people with type 2 diabetes. So the bottom line is that there's a lot of movements with different not-for-profit societies, TCOYD, JDRF, et cetera, to get type 1 diabetes folks on a higher priority list. But the bottom line is that everybody should get vaccinated when it becomes their turn. And people ask, what's the better vaccine? The best vaccine is the one that you can get now. So everybody with type 1 diabetes needs to get vaccinated as soon as possible, getting both shots, with Pfizer, Moderna, like whatever. And we're constantly trying to get people with type 1 prioritized. I will say that it's getting easier and easier as we move down these tiers for people for type 1 to find some way that they qualify, whether it's through their job or if they're providing care for a family member or something else. And now getting to the point where they get letters from their doctors even saying that they are in this high risk category. So I'm glad to see people with type 1 diabetes, I think, need to be kind of the emblematic person of getting their vaccination and all that, because it's especially important for us. So I don't know if you guys have any comments on that, but I wanted to make sure to address that.
I've just been, asking my patients at their recent visits about their thoughts on it and, where they are in terms of in line for their vaccine. I have a lot of patients who are healthcare workers, or a lot of patients who are teachers. So they sort of are in that essential worker group, but it's so frustrating because it also appears to be kind of a state-by-state decision. So I see patients in both Nebraska and Iowa, very different. Nebraska did put type 1 in the 1B group, but then they got rid of their high-risk group altogether just a week or two ago. So it's changing so much. It's state-by-state, and so it's really hard to give a blanket approach to that, but I'm recommending it to everyone, and most of my patients are, anxious to receive it if they haven't already.
And I just want to add that I'm really glad, Jeremy, to hear you say that, and Leslie, to hear you say that, because there's a lot of vaccine hesitancy across the board, and there are a lot of people that are just straight up anti-vaccination. And I'm really glad to see people in the clinician space and in the advocacy space saying that this is an important thing for people with diabetes to get. The more that we who have the opportunity to sit on these meetings and say a couple of things to people who might be listening, when we are saying that is so important, get vaccinated. I'm just really glad to hear you guys say that.
I think some people confuse autoimmunity with immune deficiency, and it's important to state that, no, you should be able to mount an immune response to this vaccine and you should get the vaccine.
Yeah, and people still say things like, what happens with your blood sugars? I've heard X, Y, and Z. I heard with that second shot, you're, like wiped out, like whatever. Really, people with diabetes do fine. I think honestly, these reactions have been completely overblown. Yeah, when you get your second shot, you might feel a little wiped out. You might feel like you have the flu. That's way better than getting COVID and being hospitalized. And your blood sugars are, different. It's probably a little bit from the reaction that, just like when you get sick, rather than the vaccine itself kind of causing that. It's more of kind of your immune response. So, personally, when I got my second vaccine, my blood sugars they were completely normal. I felt a little crappy for a day, and then that was kind of it. So please, when you can, get it. All right, so I'm just gonna go through some of these questions because they are kind of specific. Here's an interesting one. I'm concerned my endo isn't proactive. So how to deal with a provider that maybe you don't relate to. Kerri, what do you think?
Switch providers. And no knock on that endo, but that might be just the wrong healthcare professional for you. So I've always felt like being in a relationship with your doctor is like being in a relationship. And so you have to kind of try out different clinicians to find the right fit for you, the person that you can show up and see, that your insurance hopefully covers, and that you can be honest with about the stuff that you need assistance with. That's the right clinician. If you're not there with that person, then shop around if you can. I know that's kind of a sore spot too, because some people only have the opportunity to see certain people.
I'd say insider tip here, most endos, to put this lightly, don't really care. I mean, if you switch providers, they're not going to take that personally. I mean, like we realize that we're here to help, and if it's not working out, it's not working out. So you shouldn't ever feel like you're married to this relationship because it's for you. So that is important.
And I think if you're disappointed that your endo is not, helping you get to your goals, you should be specific about what those goals are, right? If you really want to improve, if you want a time in range above 90%, just because that's what you want, just, tell them. And if it's not dangerous, I'll help you do that, but if you want an average glucose of 85, maybe we're going to have a talk about why that can lead to more hypoglycemia and the data behind why that's not the best thing anymore.
Yeah. So this is kind of along these lines. Kristen says, I've been fairly tight controlled for years. I'm now 44, and I feel like I've hit a roadblock and working hard to keep my glucose in range. I know hasn't mentioned a thing about Afrezza or Tresiba. I'm going to my next appointment. These are the top of my list. So I think a couple things from that for me is that we've said a number of times, that's the whole point of TCOYD. That even if you have the best practitioner in the world, whoever that is, you might see them 2, 3, maybe 4 times a year. And the rest of it is kind of on you. So, educating yourself about these are things I heard about, they might be useful. Going see your provider, taking that information to them can make a much more, impactful visit. The best visits that I have with patients is when they come in and they are on top of it, meaning not that their blood sugars are necessarily great, but hey, I'm struggling in these specific areas. I've noticed I'm going high after lunch, or I'm having lows overnight. And then we can kind of talk about those specific problems rather than here's my information, fix me. The more it can be a team, the better kind of results, really, I think that everybody will get. I don't know if you guys have comments on that.
No, I think that sounds good.
Okay. Hello, thank you for the info. Can you please speak briefly about the issues those deal with multiple autoimmune conditions in addition to type 1 might face? So that's a good one. So broadly speaking, people with type 1 diabetes are more prone to other autoimmune conditions. And the two most common are thyroid issues, which can be low thyroid or high thyroid, and celiac disease. And those are usually things that we screen for every so often, especially if you have symptoms. And then it can be, more kind of severe autoimmune conditions, lupus, rheumatoid arthritis, inflammatory bowel disease. These things can run together. And there's no one, obviously there's no blatant statement I can make for every autoimmune disease other than to say, yeah, it does suck. It's unfortunate. You feel like when you have type 1 diabetes, that should be it. That you shouldn't be allowed to have anything else because you've been dealing with this, probably since you're a kid. And it seems unfair to get something else. But it is unfortunate. It happens. And the best advice that I can give is, trying to unbundle these things. I'm going to deal with my type 1 diabetes, and then I have my thyroid condition or whatever as much as you can. But just keeping in mind that they do run together, which is, unfortunate. I don't know, Kerri, Leslie, anything there?
I would also urge people to not be afraid to get screened for these additional things, and like not to fear a second diagnosis or a third diagnosis, but the more information that you have, the better you can deal with whatever's tossed at you. So don't be afraid to do the screening processes.
Yeah, and I think kind of dovetailing along that, Kerri, is like not just screening for autoimmune conditions, but complications in general. And that can be a taboo topic. Every year getting your protein in your urine checked and your eyes checked. And that is, I hate getting my eyes checked because for several reasons. One, the dilation thing just blows up my eyes and I'm like worthless for at least 24 hours. I can't read, I can't do anything. And two, you can only get bad news. Like you're kind of like supposed to like be okay, but if something bad happens, you feel like you failed, like whatever. And let's say that you do have a complication, you're worried about it getting worse. So I think that that's an area that a lot of people with diabetes struggle with. And it's an area, honestly, that the type 1 community can be the worst. That a lot of times the community can be really supportive, but it can be a lot of like diabetes shaming that, you like, and I think that's a self-protective mechanism. Like, I'm not going to get it because I'm doing a really good job and they just got it because they've been out of control. But the truth is it can happen to anybody. And it's just something that people need to stay on top of, and getting those annual checkups, things like that, to be vigilant about them so that you can address them when they come up.
Mm-hmm. Hard second to that completely. And I've had eye complications, and so I feel you on the eye doctor thing. But what's also nice is that my eye complications over the years have resolved themselves, which I know doesn't always happen, but it did in my case. And that was really nice to get that positive information. And also, I don't know if it's often discussed, but people with type 1 diabetes get that dry eye all of a sudden. Do you guys have that at all? Maybe it's all the computer work or whatever, but my eye doctor told me that you can put little plugs in your tear ducts that keep the tears from draining out of your eye, and it keeps your eyes moist. Ugh, weird word, but it keeps them moist better. And so I thought it was amazing that my eye doctor uses tiny little elf hammer and put these weird little plugs in my tear ducts. And that's way too much information, but I was so excited about it. It was like a good news moment at the eye doctor. That's gross.
It's funny, like, I didn't know about diabetes, but it happened when I actually got LASIK because I have horrible vision. And then I had the driest eyes in the world. And I did those. And then I was just, Niagara Falls. I just had like so much.
It's so cool.
But I think the last thing I'll say about these complications is I remember, Kerri, we were at this like children with diabetes conference, and they had this like free eye screening, like whatever. And I went in there and I was just like, kind of had a break. I'm like, I'll get my eye screened, like whatever. And the eye doctor was like, well, how long have you had diabetes? And I said, like, 20 years at that point. He's like, yeah, you don't have any like complications. Like, you've done a good job. And I like laughed, and like, I almost started crying. I was just like, nobody has ever said that you work, your butt off. And why do we work so hard? Is because we don't want anything to happen. That's all we want. We want nothing to happen. And it's hard to work years and decades with the goal of nothing. So it occurred to me then how important kind of positive feedback is, because we don't get it. So as much as you can, like celebrating the little victories of not going high after eating pizza or whatever the hell it is, like patting yourself on the back, I think is hugely important. And there's so much guilt and all that wrapped up in diabetes that we have to stop and just tell ourselves every once in a while, you're a diabetes rock star, you're kicking ass, and you're doing a good job. All right, I'll take that as just like profound agreement on you guys' part. All right, let's keep going through here. There's more like vaccine questions. Should I get it vaccinated? Another arm is my CGM. The relative spot to your vaccine relative to your CGM really, doesn't matter.
I think I always get vaccinated in my left arm since I'm a right-handed person, and I had my Dexcom in my left arm both times. Made it through unscathed.
My brother's old endo told him not to get vaccines. Well, that's dumb.
Yeah.
Would gluten cause high blood sugars if you don't have celiac? Not necessarily, other than like gluten is a lot of like carb containing,
like
thing.
high glycemic index. Like.
Yeah, so I would say it was that rather than the gluten specifically. Any tips for my brother and me? Been on T-Slim 5 weeks, brother a couple of days. Well, first of all, congrats on having a brother with type 1. So I guess new to a pump, I mean, that's something interesting to kind of talk about is,
I have a suggestion.
yeah, what do you want to say?
Specific to the T-Slim, like I have a working agreement with Tandem, unrelated to this particular conference, but so I feel like I have to just say that. But the clip for the T-Slim that comes with it, I couldn't stand it. And so I use a cell phone clip and attach it to the back of my pump. And this was the best bit of advice I could get to people because it stays on there nice and solid and it makes the wearability increase like tenfold. So
funny you say that.
So much less bulky then.
Yeah. And it stayed on there. I mean, I'm rough and tumble on this thing and it's like stayed stuck for a long time. So
well, it's funny you said that. I never talked to anybody about that, but I actually super glued my Tandem clip on because it fell off all the time. And so, that's a very practical thing, but I think, there's a lot that goes into wearing a pump and having this thing on your body and changing it, blah, blah, blah. So my advice in general for diabetes management, whether it's pumps or shots, is do what works for you. And that sounds like a cliche thing to say, but it's absolutely true. I think there can be a lot of feelings that you have to be on this or that if you're going to be a good, diabetic. And if you're on shots or you're inhaling insulin, you're doing whatever you're doing and you're doing a good job, you're doing a good job, period. It's all about kind of getting good blood sugars and having a good quality of life. And whatever system that you can find out that accomplishes both of those things is what you should be on. In the last 5 years, I've been on multiple different pumps, on completely just shots, pretty much inhaled insulin all the time and everything in between, because I'm always trying to experiment. And it doesn't have to be always about trying to get better blood sugar control, but just about like what fits with my lifestyle the best. All right. So
I'd say if you're going to make a change in what you are doing, just think about, do it at a time in your life where you have a pretty consistent schedule, not like right before you're going on a vacation or going on, a trip to Europe. I mean, just carve out some time for you to get used to your new device or whatever you're doing. When I was on my first pump, I was an intern my first year of residency, and I got my pump on a day that I wasn't on call, and the next day I worked a 30-hour shift in the ICU. And looking back, that was a horrible idea. I should not have done it on an ICU month. I should have just waited to had a more consistent schedule, but worked out okay.
What better time than during a pandemic when schedules seem frightfully consistent? So
that's a good time. Make the change.
Get it done.
A general theme coming up in some of these questions is about kind of other medications for type 1 diabetes besides insulin. And Steve gave a whole kind of talk about this. And what comes up is probably 3 drugs, maybe 4. So one is metformin. The other is these GLP-1, drugs that are injectable drugs, SGLT2 inhibitors, which are oral medications. And then some people use Insulin, which is actually the only approved drug for people with type 1 beyond insulin. So my overall comment on this topic is that I do think there's a real role for other medications besides insulin in type 1s. So when you look at kind of our treatment paradigm for type 2s, it's all about combination. They start with metformin, then you use this medication, you combine them to kind of comprehensively treat the person with diabetes. And in type 1, I think we always will need insulin. Insulin is a lifesaver, literally. But I think there might be a role for some of these other medications that can help with weight, maybe help with insulin resistance, help with time and range. And these medications, specifically the GLP-1s and SGLT2s, they do work. They help specifically with weight and blood sugars, but they have their issues. It depends on the medication, and they can be hard to get covered because they're not approved for type 1s. So I have used these medications and found that they do work, but have kind of stopped them for different reasons. And I don't know, let me start with you, Leslie, as a physician. Do people ask about these much? Do you have a general kind of answer and approach to this?
I'm open to what they want to do. I tend to not use the SGLT2s as much just because I'm within like a bigger academic group and we try to be pretty consistent with our practices. And most of my partners feel like the risk outweighs the benefit. So we're sort of not using them as a practice, except I have a handful of patients that came in on them and want to stay on them. And so I will continue, with a discussion. I have a decent number of people on metformin who just feel like it helps with keep their insulin requirements at bay, and in turn their weight at bay. And there's really not a lot of risk to it if you're not having any, stomach side effects. And then same with GLP-1s. I will bring it up if they indicate that they're frustrated about their weight or their rising insulin requirements, because again, there's stomach upset risk, but there is the potential benefit of weight loss and not a lot of known risk to using these drugs in type 1. I think the tricky thing is just I send the prescription and I have no idea, what the heck is going to happen in terms of cost and coverage. So I'm open to it. I will often bring it up if they express frustration about weight gain or rising insulin requirements, or sometimes they ask about it as well.
Cool. What about you, Kerri?
So I've been taking a GLP-1 for the better part of a year and a half, and my insurance has been generous in terms of covering it, but they didn't cover the one that worked best for me. So it was kind of frustrating. My endo had no problem writing the scripts, but I had to go through the due diligence of taking one GLP-1, proving that it didn't work, and then getting coverage for the one that did work. And that process alone was very frustrating, but the benefits of using it have outweighed the hoops I had to jump through. It becomes like one more thing that people with diabetes have to be like, well, I'd love to take an additional drug. Oh, that's so weird. But if it's going to benefit me, great, then I'll do it. But then you have to jump through all those annoying hoops too. So that's its own stressor. It was really helpful that my endo's office did a lot of the calling and the pre-auth stuff for me. I appreciated that help there.
So thank you, Kerri. Another interesting question. This person, Alyssa, says, there are no endos in Illinois. They are all leaving or retiring. Is it a difficult career? So a little bit of backstory on endocrinology. So it is an interesting specialty. So the way this works is that after medical school, you have to go through 3 years of internal medicine residency. And after that, you can be an internal medicine kind of general practitioner doctor. And to be an endocrinologist, you have to do 2 additional years of what we call fellowship. And endocrinology is one of the few specialty trainings that the average income is actually less after you go through that additional training than it is before. Meaning that most endocrinologists can make more money being an internal medicine doctor than they can be as an endocrinologist. So that tells you that it's not a financial incentive. People go into endocrinology in general because they're interested in the field or they have some compassion for it, which is good. And then the other interesting thing about endocrinology is that it's largely divided between endocrinologists that like to focus on non-diabetes and then people that focus on diabetes. And again, there's nothing wrong with this, but a lot of endos will have an interest in thyroid disease or adrenal disease or pituitary or, kind of the sex hormones. And that's where their passion lies, and that's good. But if that's the only endo in your area and they're a thyroid specialist and you have type 1 diabetes, that's tough. And even amongst the endocrinologists that like taking care of people with diabetes, it's split also between how much they know about type 1 versus type 2. So it is kind of hard to find an endocrinologist that has an interest in diabetes and a specific knowledge base in type 1 diabetes. And there's overall a general shortage of endocrinologists in the country, especially kind of in the middle of the country. And what I mean by the middle of the country is like 90% of the country. Most endos are kind of on the coast, west or east. So it does set up a tough dynamic where it might be hard if you're going to multiple different providers to find kind of someone that's right for you. That is common. And that person doesn't have to be an endocrinologist. It might be a diabetes educator that you bond with, or a nutritionist, or somebody that can help you through this. So that was a long spiel, but I do think that's important.
There are, some now like 1-year programs. So for people that are family medicine doctors or internal medicine doctors that have a specific interest in just diabetes, there's like a 1-year additional fellowship they can do to become like a diabetologist. So could be another good option if there's somebody like that in your area. Even if they didn't do an endocrine fellowship.
Yeah, and I haven't had an endocrinologist in a long time because I am one. But the ones that I did have, I honestly didn't get along with very well. And I felt like they didn't really understand or whatever. So I've definitely seen that side of it. And it's not fun. All right, things that also keep coming up, practical things, CGMs and rashes, which might be the bane of my existence. So I'm just gonna throw it to you, Kerri. Have you had experience with this or things that come up?
Yeah, dude. So I remember, I think it was like 2012 that I started to get really blistery skin allergic reactions to the adhesive for the devices I was wearing. And then that went on for years. I had to use like a J&J Tough Pad underneath. I was spraying Flonase on the skin and letting that dry before I'd put my my devices on. But then all of a sudden, I think it was like 2018 that the CGM company changed their adhesive, like chemical makeup. And all of a sudden I wasn't allergic to it. And I don't even want to say that out loud because it makes me think it's just all of a sudden going to turn back and now I'm going to be allergic to all of it. But that was the only thing that fixed it. And so that's been very frustrating. And I know that there's been a cyclical thing where a lot of different people are popping rashes for different devices and that sort of stuff. There's no good thing that helps. What I've seen the most anecdotal evidence from the community is that what they do after they have a rash. So like the topical ointments they put on to help deal with the scritchy feeling that you get afterwards and that sort of thing. But in terms of preventing it, it's like a black hole.
Leslie, what about you?
I mean, I think some people had I'm happy that Kerri's rashes got better. I think some people had the opposite problem in 2018 and that they never had a rash from a Dexcom and then they developed a rash because of the new adhesive. So, I mean, yeah, there's tons of tips and tricks, which some people can do one and get away with it. And some people have to do just like this whole routine. And it's a mix of trying to prevent it in the first place, also then treating it when it happens. And so there's the Flonase, there's the kind of the hydrocolloid patches, like the tough pad that you can put on top and shoot it through. There's like rubbing milk of magnesia on it, I think, which is one of our educators has kind of a whole long text that we can put into people's instructions when we see them for a visit to help guide them through it. And some people, can just do one step and some people have to go through the whole method.
Yeah, but I mean, what a pain. I mean, like none of us are like just jonesing to throw a CGM on, and then like on top of that, like we got to deal with like rashes and stuff, which are, they've like, for my patients, they've gotten much worse in the last, year or two since Dexcom has changed their adhesive. I will say that people that have gone from Dexcom to the Libre tend to like, that can be a solution. Mm-hmm. The problem is, what if you're on, a tandem pump and it only talks to the Dexcom, then you're out, of that communication. So that stinks. And there is, the Eversense, which you can get implanted. So there's usually ways to figure out the CGM component of it. But the issue comes when people want to stay on the Dexcom, for example, which is reasonable because it works with their pump. And then you have to find all these ways to just, not get these like, hives and stuff like that. So it's something I'm seeing more and more, and it's definitely frustrating.
I just want to add something. There's a whole Facebook group that has like hundreds of members about, I think it's called the Dexcom adhesive rash, or it's got like a Dexcom rash sort of title to it, where people are sharing the newest best practices that they're using to deal with adhesive irritation.
And now the Libre 2 is going to work with Dexcom, right? Or I'm sorry, Libre 2 with Omnipod and their upcoming hybrid closed loop. So it could be an option.
There's questions about looping, and, these are people that do kind of their own do-it-yourself artificial pancreas system. Whatever thoughts on that? I think you're talking to kind of a progressive group, and that, we're all like intrinsically fine with this idea of people doing something, that helps them. And actually, there's been studies now with loop showing that it's effective, it's safe, etc. I have heard stories of people saying that my endocrinologist won't see me anymore because I'm using one of these do-it-yourself systems. And again, my advice would be that you got to find a different practitioner, and which is fine. So I think, as long as you're doing something that's reasonably like, within the realm of being safe and things like that, then there's nothing wrong with that. And the reason that these systems have come to be is because it takes so long to get these things approved through the FDA and through channels, which has some merit. It's important to make sure these things are safe, but they can take a long time. So most of my patients that are looping now are on the Omnipod, and they just want the Omnipod to do something like the Control-IQ will do. If you have no idea what the hell we're talking about with loop, you can just Google it. And it's basically a do-it-yourself system that makes an Omnipod more like Control-IQ, where it can adjust basal rates and things like that. It's not a fully closed loop system yet. So we're right at time now. So that actually went by pretty quick. So there's a lot of questions that we haven't specifically answered, and we will put them online on our like TCOYD blog and answer all these. So all you folks that feel like you didn't get answered or whatever, just check back, and we'll have information in our emails after the conference about how to do that. So thanks, Kerri, Leslie. I think a silver lining of COVID is I get to see you guys actually more, maybe. I mean, I know it's weird. I don't actually get to see you, but I get to see you. So thanks for doing this. And I don't know if we said in the beginning, but Kerri, you're in Rhode Island, and Leslie in Omaha, and different like time zones. We have people from 40 different countries here. So it is a way to kind of get people talking without having to physically be together. So thanks everybody. Really appreciate it. And I will log off, and then don't make sure to go back to the auditorium, check out when the next talk is. And thanks again.
Bye. Thank you.
Bye guys.